Welcome to Medicine Simplified. In today's episode, we're exploring rheumatic fever, a silent danger that can arise from untreated infection. Definition of rheumatic fever. Rheumatic fever is a systemic, immune-mediated disease that can arise as a complication of untreated or inadequately treated Group A Streptococcus pharyngitis, commonly known as strep throat. The symptoms presents 2 to 4 weeks after from Group A Streptococcus infections. Epidemiology of rheumatic fever. 1. Incidence. More prevalent in underdeveloped countries. Populations living in overcrowded conditions. 2. Age. Children's aged 5 to 15 years. Young adults 20 to 30 years. 3. Gender. Acute rheumatic fever affects both sexes equally. Chronic rheumatic fever is more prevalent in females. Pathophysiology of rheumatic fever. Untreated Group A Streptococcus pharyngitis, antigenic mimicry between streptococcal M proteins and human proteins, cardiac myosin, activation of T and B lymphocytes. Antibody production, antistreptolysin O, cross-reacts with host tissues, cytokine release, inflammation and immune cell infiltration, lymphocytes, macrophages, tissue damage of some organs. Pathology of rheumatic fever. Sites of immune reaction. 1. Joints, most common site leading to arthritis. 2. Heart, can lead to pancreatitis. 3. Skin, characteristic rash and lesions. 4. Brain, affects basal ganglia. 5. Serous sac, pleural and peritoneum. Forms of inflammation in rheumatic fever. 1. Proliferative inflammation. Involves fibrosis, associated with endocarditis and myocarditis, heals with fibrosis leading to lesions called Ascoff nodules. 2. Exudative inflammation. No fibrosis, involves serous sac, heals without fibrosis. Ascoff's nodule, in microscope. Shows central fibrinoid degeneration surrounded with macrophages, T lymphocyte, plasma cells, and Ascoff's giant cell. All these are surrounded by fibroblast. Clinical manifestations of rheumatic fever. 1. Major manifestations. Carditis. Polyarthritis. Sydenham chorea. Erythema marginatum. Subcutaneous nodules. 2. Minor manifestations. Fever. Arthralgia. History of previous rheumatic fever. Elevated ESR, CRP, WBC. Prolonged PR interval on ECG. 3. Manifestations of active rheumatic fever. Pallor. Fever. Tachycardia. Elevated ESR, TLC, CRP. Diagnosis of acute rheumatic fever. Modified Jones criteria. Require 2 major or 1 major plus 2 minor criteria. Plus. Evidence of a recent streptococcal infection by 1. Positive throat culture. 2. Rapid antigen test. 3. History of recent scarlet fever. Investigation of acute rheumatic fever. 1. Laboratory investigations. Throat culture. CBC. ESR. CRP. ASO chest X-ray. ECG. 2. Modified Jones criteria. Major criteria. Minor criteria. Treatment of rheumatic fever. 1. Supportive treatment. Bed rest until ESR and temperature return to normal. 2. Eradication of Group A Streptococcus. Benzathine penicillin G 1.2 millions international units single dose intramuscular. Or phenoxymethyl penicillin V 250 mg every 6 hours for 10 days, if allergic for penicillin, erythromycin or cephalosporin are used. Non-steroidal anti-inflammatory drugs as aspirin for treatment the symptoms. Corticosteroids as prednisone in case of carditis or severe arthritis. 3. Treatment of complication. 4. Prophylaxis treatment. Benzathine penicillin G 1.2 million international units every 21 days intramuscular. Or phenoxymethyl penicillin V 250 mg every 6 hours. Durations of treatments. 1. Without carditis, prophylaxis for 5 years. 2. With carditis, prophylaxis for 10 years. 3. With cardiac defect, long life prophylaxis or until valve surgery. Rheumatic fever reminds us, prevention starts with awareness. Treat strep throat early, prioritize prophylaxis, and protect hearts for life. If this video enlightened you, share it to spread hope. Together, we can outsmart this disease. Stay informed. Stay healthy. Consult your doctor. Thanks for watching. Don't forget to subscribe for more medical insights. Until next time, guard your health and your heart.